Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, and welcome to a podcast series brought to you by the American Academy of Orthopedic Manual Physical Therapy, or more affectionately known as AOMT. My name is Kevin MacPherson, and today I have the privilege of interviewing Sharon Wang-Price in regards to her research entitled The Effects of Tactile Feedback on Lumbar Multifidus Muscle Activity in Asymptomatic Healthy Adults and Patients with Low Back Pain. Now, before we get into the interview, some background on Sharon includes an entry-level degree from National Taiwan University, as well as a master's degree in sports physical therapy from the University of Pittsburgh. Now, after practicing for some time, Sharon decided she wanted to learn how to answer some of her clinical questions, and she underwent PhD training through Texas Women's University, which is where she currently functions as a full-time professor and coordinator of professional studies. Now, Sharon is a fellow through the Academy and underwent her training through the North American Institute of Orthopedic Manual Therapy. Furthermore, she is a board-certified specialist in orthopedic physical therapy and does maintain licensure in 2 states. So, Sharon, you have definitely been very active within the Academy. If you don't mind, give us a little bit of a background with all of the things that you've done both with and for the Academy.
I've been a fellow since 2009, and since then, I've been invited to be research panel, which is a subcommittee for a research committee. And about 4 years ago, I was asked to serve on the research committee, and I've been member since. And last year, I basically started serving as co-chair with Alicia.
I got to work for quite some time with Alicia when she was at UIC. So wow. She is a good friend, and she definitely ropes me into doing several reviews for posters and whatnot pretty much every year.
I said, we definitely will give you more work to do.
Yes, I've gotten to the point where I try to stay away from her now. Just kidding. I'm not serious. So, Sharon, now that we've got a little bit of a background on you, can you tell us why you chose to do fellowship? What brought you there?
Well, like I said, I was a full-time clinician, but when I was in PT school eons ago, we done very little joint mobilization and joint manipulation. And the joint manipulation was unheard of in our physical therapy curriculum. So believe it or not, I actually learned spinal joint mobilization for the first time when I studied for my master's degrees at the University of Pittsburgh, when Dick Urquhart was an instructor then. Now you know how long ago was that. Then I practiced as a full-time clinician for about 10 to 11 years before I took an academic position at Texas Women's University. While I was a full-time clinician, I always valued manual therapy skills and appreciate its effects on the patients, although most of the time I did not understand the underlying mechanism. So at the time I took the academic position, Tim Flynn had just developed the clinical prediction rule for lumbar pelvic manipulation. Although I was confident in my joint and soft tissue mobilization in terms of skills and knowledge, I was not as confident in my manipulation skills at all. So to further develop my manual therapy knowledge and skills, specifically manipulation, I went through the manual therapy certification with North American Institute of Orthopedic Manual Therapy. As a result, I realized that a more vigorous and systematic curriculum would be a more effective way to acquire manual therapy knowledge and skills. And the fellowship training, I think, was very tough, really made me a better clinician in terms of a clinical reasoning and not just a better manipulator. So, And I was very fortunate that I have great mentors and great colleagues to go through the process with me and inspire me to be a better manual therapist.
Having gone through fellowship as well, I can honestly say that I don't know anybody who will say that it was a very fun experience to go through, but it's definitely fun to reminisce about. So
Correct.
It sounds like that would be true in your circumstance as well.
Yes, very true.
Now, Sharon, let's talk about your research really quickly. If you don't mind, could you go ahead and briefly just describe the project and the results you got?
Sure. As the title indicated, we were interested in knowing whether or not tactile feedback will affect muscle activation of the lumbar multifidus muscle in patients with low back pain. There were two cohorts in this study. One cohort consisted of 20 asymptomatic healthy adults who did not have existing low back pain and had not had low back pain in the previous 6 months. And the other cohort consists of patients with existing low back pain and the intensity of their low back pain at least 2 out of 10 on the MPRS score. Before data collection, we showed each participant where the lumbar multifidus muscle is and then told them that we would put our hand over the skin of this muscle for this study. We used a surface EMG to collect lumbar multifidus muscle activity, and each participant was asked to perform 5 tasks in the same order. So during the first 2 tasks, we collected EMG activity while the participant was at rest in the prone position under 2 conditions. First, without tactile feedback, and then with tactile feedback. For the next 2 tasks, we collected EMG activity while the participant performed a contralateral arm lift task, lifting the left arm for right lumbar multifidus muscle and lifting the right arm for the left lumbar multifidi. Again, under 2 conditions, first without tactile feedback and then with the tactile feedback. At the last, the participant performed a bilateral arm lift while one investigator provided resistance on the opposite elbow to obtain a maximal voluntary isometric contraction. And this was used to normalize the EMG activity collected at rest and during contralateral arm lifts. And the result was not what we anticipated. We found that there were no significant differences between groups at rest or during the contralateral arm lift. However, all participants had significantly decreased muscle activation under tactile feedback condition. Well, needless to say that this result is the complete opposite of what we anticipated. So therefore, we concluded that tactile feedback using direct hand contact appeared to provide an inhibitory effect on lumbar multifidus muscle activity. From a clinical perspective, direct hand contact may lessen the desired treatment effect.
And I found that quite interesting. When I was reading the article, I kind of was thinking from a pain side of things, we do have a little bit of evidence out there that says you have overactivation of the lumbar multifidus more for chronic pain patients. But when I saw it, kind of a similar occurrence in our asymptomatics, it threw me off.
Yes, if you realized, we also asked the participant if they felt that tactile conditioning would be helpful to activate their lumbar multifidus muscle. So we did reported that 35% of asymptomatic participants and 50% patients with low back pain perceived tactile feedback to be helpful for activating the lumbar multifidus muscle. Mm-hmm. Whereas the lumbar multifidus muscles actually was reduced when tactile stimulation was applied. And originally we thought, well, that probably there's a disconnection between the participants' perception of a tactile feedback and their ability to perform lumbar multifidus contraction. Mm-hmm. And the study also showed that the patient with a low back pain has a decreased tactile acuity. But this does not explain why asymptomatic participants also had the same results. We were thinking it likely could be the called Hawthorne effect, meaning that the participants consider tactile feedback to be helpful for lumbar multifidus contraction because we told them that was the purpose of study. Yeah. And as you are aware of that, recently we are really talk about the pain science education. We basically saying that if you use of a positive and proper word, that might have a favorable clinical outcomes. It's basically probably demonstrate a power of suggestion.
That actually brings me to another question, because I happen to work right down the hall from Joel Biloski. So there's a lot of pain science that occurs in my current facility. When we look at the kind of the research that I've reviewed, and I am by no means an expert in this area, but when we look at the research for this disconnect between the body's perception or the brain's perception of the low back and some of the function of the muscles, I've seen some research that says visual is kind of not as good to use versus tactile when you're trying to get that person to just focus on the area, improve their homunculus, for lack of a better term. So I'm curious, if we go back, not so much just to the Hawthorne effect just yet. I know you stated that you showed the participants where the lumbar multifidus is. Did you do that through a visual or a tactile mechanism?
We actually did both. We actually show a picture of the lumbar multifidus is in an anatomical chart. We also tell them that our hand going to put over the lumbar multifidus. So I think we provide both visual and the tactile.
Gotcha. So you actually covered both bases. It's interesting to me because of the pain science that I'm exposed to on a near daily basis, whether I like it or not, is always there. I mean, I guess that kind of brings me up to another question. You know, when you looked at developing this question in specific, what were the thoughts or the triggers historically that said, hey, I need to look at this? What drove you to this research question?
That was a very good question. The idea of this study actually from the results of our verbal instruction study, which was published in JMNT last year. And a few years ago, a group of Australian researchers, including Julie Hyde and Paul Hodges, show how important it is to recruit the lumbar multifidus in patients with low back pain. So they suggest a verbal instruction: swell the muscle under my fingers for activating the lumbar multifidus. In hindsight, I always joke about in the clinic, which patient would really understand this instruction? So
Yes.
So our first study was looking at the different verbal instruction on lumbar multifidus activation. And when we found out the instruction swell the muscle was equally effective as compared to the others, such as tilt your pelvis forward without really doing it and pull your belly button toward your spine. So based on that results of that study, we thought the contact of the ultrasound transducer with the skin might provide a tactile stimulation to the participant. And also, in clinically, when we try to demonstrate the lumbar multifidus muscle contraction, but this muscle is deeper and really difficult to show the muscle contraction. So what we do in clinically, we usually do is put our hands over there, and then we give the verbal instruction to see if the muscle work. And nobody had to look at the effect of a tactile feedback. Therefore, all this prompted us to conduct this study.
Okay. From a clinical standpoint, one of the things that I started to kind of have a little bit of a disconnect with that you 100% address later on in the limitations or the discussion component was that this tactile stimulus can be different than what you see in clinical practice. So can you, for the listeners out there that are not researchers and don't really have an idea of how using EMG works and whatnot, can you go ahead and explain why you chose a stationary and relatively superficial contact as opposed to some of the other clinical models out there?
Yes, we did think about that during the design of the research. The reason we chose a continuous light hand contact because of the limitation of electromyography, which is considered a gold standard for assessing muscle activity. Clinically, like you pointed out earlier, we usually use a light tapping or apply a deep pressure for tactile feedback rather than the continuous hand contact used in the study. However, light tapping and the deep pressure will affect the muscle activity picked up by the surface EMG. So then will affect the results. interestingly, we actually conducted a pilot study and tried to record the lumbar multifidus muscle immediately after 10 light tapping. But the collected EMG activity was inconsistent from the one trial to the next. Therefore, we chose a continuous light contact, although it was not performed clinically as often as light tapping or applied deep pressure, but we do have a limitation of the equipment.
Yeah, just not having the equipment needed yet to be able to make that measure. This kind of goes off topic just for a second. When I come back to your findings, when we look at the symptomatic versus the asymptomatic group, did you see a significant difference, or is it possible even to see a significant difference with the overall resting electromyographic activity between those two groups with the methodology that we have available?
We were very surprised based on the results of our study. We actually saw the low back pain patient increased lumbar multifidus just a little bit higher than the asymptomatic patients. So there could be a couple factors affecting that result. One was that we think that the patient probably have some muscle activation in response to the low back pain itself. So some kind of muscle spasm type of activation. And the other factors could be we use the maximal voluntary isometric contraction as a baseline for normalize the resting and the contralateral muscle activity, just because in order to compare from one person to the other person, we have to normalize the EMG data. And we think that while we are performing the maximal voluntary isometric contraction, the patient with the low back pain, we might not get the true maxima activity, therefore probably affect that result. Again, it's due to some kind of limitation of the instrument.
I mean, that makes a lot of sense. If their relative ceiling for that maximal voluntary contraction has dropped, then any activity that they do will be perceived as closer to their maximal voluntary contraction. Okay, that makes a lot of sense to me. So as a clinician, what's my main takeaway? What am I going to pull out of this to bring in on Monday morning?
From a research point of view, I thought that was a more challenging questions than to answer the research questions. So, but I would suggest that clinicians should not rely on just one strategy to increase muscle activation if that's the goal of the treatment. Instead, clinicians could consider using various approaches to ensure muscle activations, such as verbal cues, tactile stimulation or palpation, demonstration, or kinesiotaping, which has been shown have some effectiveness on muscle activation. And also be aware that patients' perception of their physical performance, such as the amount of a muscle contraction, might not be equal to their actual performance.
There's nothing more relieving to most clinicians to know that this is something to contribute to us understanding or getting a better grasp of the complexity, but knowing that there's still enough complexity that we need to keep up with reasoning, and we should never just kind of default to the quintessential cookie cutter treatments.
That's well said.
So what's the next step to progress this line of research questioning? Where do you head next?
Well, it's never-ending research because we always find something unexpectedly, and then we come out the next question. So I do have a line of questions based on the results of the study. To name a few, the first question I would like to know was, would the duration of the hand contact change in muscle activation of the lumbar multifidus? Or as we discussed earlier, with different tactile feedback, such as light tapping or deep pressure, will increase the lumbar multifidus muscle activation. And if so, how by how much? And in this case, is there any instrument better than EMG for assessing lumbar muscle activation? Or would adding a demonstration of the exercise affect lumbar muscle activation? The other things were watching an ultrasound video clip of a lumbar multifidus contraction improve the lumbar multifidus contraction. and that will be the visual feedback. Is there any other strategy more effective to recruit the lumbar multifidus contraction, or we have to do multimodal approaches?
Okay. So if we go back to that ultrasound, just to make sure I understand, you would use that more as a biofeedback mechanism as opposed to them just watching a random clip, correct?
Correct. Instead of looking at their own, we can consider to looking at the muscle activation do occur of other people, and that provide a visual feedback.
Oh, I see. So literally it would be a full demonstration. Like if I were to imagine the scene, it would be the subject comes in, sits down in a chair or in the assessment position, and then you would show the video with a person lifting their leg and the simultaneous recording of that person's multifidus being recorded while they're lifting, not leg, in this case, the arms. Am I envisioning that correctly?
It could be looked in two ways. I think that the research has shown that biofeedback of their own activation could provide some effectiveness. For example, it decreased low back pain, but did not specifically look at if the activation do increase. But what I meant was that if we show a video clip of the ultrasound in people who really can activate the muscle, and then basically telling, hey, this is what our goal is, and then we can reinforce their own activation.
Oh, okay. Gotcha. So obviously you had a lot of questions that have been built up from this, and you've really given us some good insight into some directions that you're going. What is the main thing that you're working on now to progress our profession forward? Because when I review the articles that you've put forth, I think I saw several that would look at low back pain, a lot of cervical. I've seen hip and knee. I mean, you are adding to our research body like crazy. So what are you working on currently?
Well, I thought that was the best secret in town. Anyway, we were very excited. The results are this line of the study. So we're going to use the same EMG protocol, and we were trying to find out if a dry needling will affect lumbar multifidus muscle activation in patients with a low back pain. I know Sharon, I'm hoping I'm pronouncing his name correctly. Sharon Hover and look the dry needling effect on muscle thickness using ultrasound imaging, but realizing that ultrasound did not give the whole picture of a muscle activation. So hoping we can use the EMG to look into the entire muscle activations. So in addition to look at the effect of a dry needling on lumbar multifidus activation, we also want to compare two types of dry needling techniques. One's the in situ technique, meaning that once the needle is inserted, the needle stays there for a period of time. The other dry needling technique is with the needle manipulation technique. Try to avoid using the word trigger point dry needling. So in this case, we piston several times after the needle is inserted. And we hope that we have the results to present in 2019 AM annual conference. So stay tuned.
Oh, that'd be very interesting. So when I think about that study, because I've been trained in dry needling, with that, are you going to normalize the time, like for the indwelling versus the pistoning? Is it going to be different time periods that you're doing that with?
Yes, we are trying to do is limit the in situ time to 10 minutes. Although that was based on Donna's suggestions, that because I think several dry needling studies shows that you have to be minimum 10 to 30 minutes. So we picked the 10 just because when we do piston, we don't stay the needle that long period of time. So we make sure we piston a minimum 10 to 15 times. So get that the same time effect.
Okay. Gotcha. Having done the pistoning, typically the common clinical goal is to try to at least get the patient to perceive a twitch reflex, or obviously better if the clinician can. Are you guys looking at that twitch reflex, or is that just a little too much for right now?
No, we actually don't. I think in the recent article, and they showed that local twitch was not necessary to have the same treatment effect.
Oh,
So, and it's really difficult to predict if we have a local twitch or not. But we do record if there is a local twitch.
okay. Having a good grasp about your research and the direction it's going, knowing that you're trying to get us to the mechanisms behind the newer treatments out there and whatnot, is all stimulating. For me as a clinician, it's very rewarding to be able to look at this work and be able to apply it to what I do when I go in to start seeing patients. And I think part of that is driven by just the overall desire of every person involved to just help move the profession forward in one way or another. So what would you say to somebody who's considering fellowship? Where would you point them?
This is a very interesting question. I was a full-time clinician before I jumped into what's called a dog world as an academician and educator. And I have to say that my experience with a fellowship training is a turning point, not only developing my clinical skills, and then most importantly is my clinical reasoning skills. I actually apply some of my reasoning for my research as well, because I want to know how that worked. Mm-hmm. And what the underlying mechanism of all this manual therapy worked. And so I really highly recommend a fellowship training program for physical therapists who really want to make a difference in their own practice, mm-hmm. Not just be a better physical therapist or better manipulator. They are really have to, I think the training process really help them to develop the clinical reasoning and then have a lasting impact on their own patients.
Mm-hmm. Well, Sharon, that's very helpful for our listeners to be able to get a feel for your research. Going forward, we look forward to all of the things that you do for the association, and I hope you have a wonderful rest of the week.
Thank you so much, and thank you the opportunity for presenting or talking about my research.
It's been a pleasure. So actually, when you said that, when you got to the point about kinesiotaping, this is another thing that I kind of thought about and really forgot until just now. What are your thoughts about the EMG application? Do you think that there was any kind of interaction between those recording tabs and the muscles underneath?
We actually thought about that. The EMG, the electrode, could provide some tactile feedback, just like kinesiotaping, just like the ultrasound transducers. However, since everybody treated the same, mm-hmm. and then we put the EMG electrode in the same place, while hoping that will serve as a baseline, just because everybody treated it equally. So that's we try to minimize that effect as compared to the ultrasound transducer, because that applied by the operator, and the pressure of the application of the transducer could affect the EMG activity.
Gotcha. So then, if I understand correctly, then it is possible that even though that was kind of controlled through both groups, since both groups did have a tendency to show a decrease in activation, is it possible that the hand contact as well as that tape, or the tape by itself and the hand contact, kind of built on each other?
We don't know for sure. We have a couple hypotheses mm-hmm. About why decrease the muscle activation with hand contact. We think it could be the hand contact were providing inhibitory responses mm-hmm. As compared to some of the kinesiotaping actually going to facilitate the muscle activity. We thought could be we are kind of applied a inhibitory taping because the theory was if you put the kinesiotape parallel to the muscle fiber, which will increase or facilitate muscle activity, while you put your hands or kinesiotape across the muscle fiber will serve as inhibitory. Mm-hmm. effect. So our hands pretty much is somewhat cross over the muscle fiber orientation, but we do not understand the underlying mechanism of this phenomenon. The other hypothesis was the temperature of the hand, since temperature of the hand could also affect EMG or muscle activity. So that's the research showed that skin temperature increases and the muscle activity actually decreases. So that could be what's going on underneath.
I mean, it's all fascinating. And of course, anytime you've got a research paper, it forces you to now ask even more questions.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.